Bismillah ar-Rahman ar-Rahim. Our topic today is again hypertension during pregnancy, but in a case-based discussion. Case number one. An 18 years old prime gravida woman at 28 weeks gestation comes into the obstetrical triage unit complaining of decreased fetal movement and headache. So she complained from headache. Her prenatal history is unremarkable. I mean, history before pregnancy is unremarkable. Her blood pressure in the first trimester was in the normal range. At the time of arrival on examination, her blood pressure is 170 over 110, so it is severe. Heart rate is 98 beats per minute, temperature 37, and respiratory rate 12 breaths per minute. On examinations of the chest, her heart and lung examinations are normal. And on examinations of the abdomen, it was not tender and no contractions, and the fundal height goes with dates. The fetal heart was in the normal range with occasional variable deceleration on external fetal monitoring. And PV examination shows unripe cervix. So these are these findings by history and examination. So this case is a case of severe hypertension. Now we want to know which is which type it is. So we sent for the investigation. CBC, hemoglobin level was 12 gram per deciliter. Platelets was 110,000. Glucose was normal. SGOT, SGPT was in the normal range. LDH was normal. Serum creatinine level is 0.6 milligram per deciliter, which is normal. And the urine analysis shows 3 plus protein on dipstick, which is a qualitative way to measure it. So she is a case of severe preeclampsia. Now, we have to always remember the signs and symptoms of severe preeclampsia. Symptoms specific for them is what? We have headache, blurring of vision, epigastric pain, right hypochondrial pain, nausea and vomiting, rapidly increasing weight with oedema, mainly non-dependent oedema, which is the oedema on the face and oedema on the hands. So whenever we handle the woman, she is pregnant with one of these symptoms, take the opportunity to measure the blood pressure. Now, how we measure the blood pressure during pregnancy? We should take a special consideration. Two ways is there. The first one advocated or recommended by the American College of OB/GYN, which is in the sitting position. Patients should be comfortably seated, legs uncrossed, the back and arm supported. The middle of the blood pressure cuff on the upper arm should be with the level of the heart, and she should be relaxed and not talking. And this is also recommended by Society of OB/GYN of Canada. Is there other positions advised by other society and other guideline? Yeah, yes, which is in supine position, but with special consideration. So the Society of Obstetric of Medicine of Australia and New Zealand and the American Heart Association Council on High Blood Pressure Research suggest measurements on the left arm in the left lateral recombinancy position is a reasonable alternative to the seated position, but during labor, or especially during labor. But however, the American College cautions the blood pressure measurement should not be taken in the upper arm with a woman in the left lateral recombinancy position, because doing so will give falsely lower blood pressure reading. So American College is still recommend what? Still recommend measurements of it even in labor in a sitting position. So according to these guidelines, we can measure it in a sitting position, and we can measure it in what? We can measure it in a left lateral recombinancy position. Now, as we said, the women should have their blood pressure measurements after a period of rest in a quiet environment and be in a sitting position with their arm at the level of the heart and using an appropriately sized cuff. What does it mean, appropriately sized cuff? It means 1.5 times the circumference of the arm. The arm with a higher blood pressure value should be used for hypertension diagnosis and blood pressure monitoring. What does it mean? Suppose we measure the blood pressures on the right and on the left arm, and the blood pressures on the left arm was higher than the blood pressure on the right. We should use the left hand, we should rely on the left hand measurements, and we follow the patients on the left hand measurements. Non-severe elevated blood pressure should be re-measured at the same visits with at least a gap of 15 minutes from the first measurement. What does it mean? If we measure the blood pressures initially and it was 140 over 90, 150 over 100, we should measure it again on at least 15 minutes apart, up to 4 hours apart. But if we have a high blood pressure measurement with all above considerations taken while we are measuring it, this is a case of severe hypertension and doesn't always necessitate repeat blood pressure measurements. And this is the proper way to measure the blood pressure. As we see here, we see in the sitting positions, the left arm, the instruments with the level of the left arm with the level of the heart in sitting position like this. Now, how to assess proteinuria in hypertensive disorder of a pregnancy. So all of us now, we know how to measure the blood pressure and difference school. Now, how to assess proteinuria in hypertensive disorder of pregnancy. And this is, again, is important. Using a dipstick for the reading of proteinuria is a qualitative way of measurement. So use an automated reagent strip reading device for dipstick screening for proteinuria in pregnant women in secondary care setting. Don't use first morning urine void to quantify proteinuria in the pregnant woman. And don't routinely use 24-hour urine collection to quantify proteinuria in a pregnant woman. Now, if dipstick screening is positive, I said, even if one? I said, yes, even if one. And she had hypertension severe. Use one of two. Either we use albumin creatinine ratio or we use a protein creatinine ratio to quantify proteinuria in a pregnant woman. يعني لازم أفهم شيئا. there is a qualitative way and there is a quantitative way. Qualitative way استخدم بيها الreagent strip, بينما quantitative way we use either collections of 24-hour collections of urine and we measure the protein in it, or we use albumin creatinine ratio or protein creatinine ratio. Now, if we use a protein creatinine ratio to quantify proteinuria in a pregnant woman, cutoff level of significance is 30 milligram per millimole. If the result is 30 milligram per millimole or above, and there is still uncertainty about the diagnosis of preeclampsia, consider retesting on a new sample alongside clinical review. I mean, if we have, for example, mild and moderate preeclampsia, and we measure it, and it was 30 milligram per millimole, if the blood pressure becomes severe, we should repeat it again. What about albumin creatinine ratio? Is an alternative one. 8 milligram per millimole is a diagnostic threshold for proteinuria in hypertensive disorders during pregnancy. If the result is 8 milligram per millimole or above, and there is still uncertainty about the diagnosis of preeclampsia, consider retesting. What are your next steps in the management? And what are the important considerations in managing her pregnancy? Starting with the management of pregnancy with severe preeclampsia, we have to admit the patients to the hospital. Can I ask questions important? Even if she is a mild, I said yes. Even if she is a moderate, I said yes. Even if she is severe, I said must. Why? Because we cannot know from the beginning that this mild form will not go to moderate or severe form. But in severe form, definitely it necessitates admission to the hospital. Two, antihypertensive pharmacological treatment should be started. The aim of it is to control the blood pressure and keep it in the range of 135/85 and less. How frequent we should measure the blood pressure, and this is very important. A blood pressure measurements every 15 to 30 minutes until the blood pressure is less than 160/110. Then at least four times per day while the woman is in an inpatient depending on clinical circumstances. What does it mean? If the woman is in severe form, we have to measure it every 15 to 30 minutes till stabilization. When it becomes stable, we have to measure it at least four times per day uh, in inpatient women. What about diabetic proteinuria? Diabetic proteinuria testing only repeated if clinically indicated. For example, if a new symptoms and signs develop or if there is uncertainty over the diagnosis. A blood test for the measurements of full blood counts, liver function test, renal function test, repeated 3 times per week, at least 3 times per week. What about fetal assessment? Offer fetal heart auscultations at every antenatal appointment. Carry out ultrasound assessments of the fetus at diagnosis, and if normal, we have to repeat it every 2 weeks. Carry out CTG at diagnosis and then only if clinically indicated. So this is how frequently we measure the blood pressure, how frequently we do albumin protein in urine, how frequently we sense for blood tests, and how frequently we assess the fetal well-being according to the guidelines. This is very important. Careful monitoring of both the maternal and fetal condition and may be influenced by the gestational age of the fetus at the time of the diagnosis. What does it mean? It means that the management, proper management, and the ultimate measurements will finally depend on what? Will depend on the weeks of gestation of the fetus. Delivery is the only cure, as we know, and the health of the mother should be the primary concern. So I should take it in consideration always that even if she is pregnant with a preterm fetus, we should take the priority for the mother as far as we can. Now, blood pressure should be kept below 160/100 to avoid cerebral vascular accidents in the mother. Labetalol has replaced hydrolysine as the drug of choice for treating severe hypertension in many centers. It may be given in this way: 20 to 40 milligram IV every 10 to 15 minutes for a maximum of 220. Does invasive cardiovascular hemodynamic monitoring is necessary? No, it is rarely necessary. Urinary output must be closely monitored for the development of oliguria. Urinary excretions of protein should be measured on a regular basis. So we have to know that labetalol has to replace hydrolysine in this protocol. What about magnesium sulfate? We will take it in two views: NICE guidelines protocol for it and American College guidelines for it, and the differences between the two. Use the collaborative eclampsia trial regime for administrations of magnesium sulfate, which is a loading dose of 4 to 60 grams should be given intravenously over 5 to 15 minutes, followed by an infusion of 1 gram per hour, and we have to maintain it for 24 hours after the last fit or for prophylaxis. If the woman has had an eclamptic fit, the infusion should be continued, as we said, for 24 hours after the last fit. If she had recurrent attack of fit, we can give half the dose. But Also, we can go up to 4 grams intravenously, again, over 5 to 15 minutes. Don't use diazepam, phenytoin, or other anticonvulsant as an alternative to magnesium sulfate in women with eclampsia unless highly indicated. This is what NICE guidelines said. What about American College guidelines sets? Seizure prophylaxis against magnesium sulfate is recommended, especially if there are signs of CNS irritation as a prophylaxis. Most protocol for magnesium sulfate recommend an IV bolus of 4 to 6 grams over 20 minutes. They extend it to 20 minutes, followed by an infusion of 1 to 2 grams per hour. This is usually continued throughout labor and for the first 24 hours of the postpartum period. So they say, it may continue longer than this if neurological symptoms persist and there is ongoing concern for seizure. The patient should be monitored closely for respiratory depression, which is a primary concern with magnesium sulfate therapy. Before we go for laboratory tests, when we monitor the women with magnesium sulfate, we should keep in mind how to monitor this woman. We depend on the respiratory rate, we depend on the urine output, and we depend on the patellar reflex, as we said in the first lecture. Respiratory rate, because the drugs act centrally, so they may have the respiratory depressions, and we have to monitor it with cautions. Urine output, because as we said in the first lecture, magnesium sulfate is secreted by the kidney. So if we have oliguria because of the disease, we have to decrease the rate and even we have to switch off. And we have to follow the patients on it with examinations of the patellar reflexes. Why? Because it is the first sign that disappear. So if it decrease or disappear, we have to switch off, or we have to decrease, and we have to measure the blood level of magnesium sulfate. And all of us, we know the antidote of magnesium sulfate. Laboratory studies. This is very important. To screen for HELLP syndrome are important. Why? As changes in these parameters may be unrecognized clinically. Why? Hemolysis may sometimes difficult to see yellowish discolorations of the sclera. Elevated liver enzyme, not necessarily we have yellowish discoloration of the sclera. And low platelets count. So, screen for it is important. Thrombocytopenia may predispose the patient to bleeding problem and may be an indication for delivery. So in AGSL, what are the indications for imminent delivery? One of them is what? Is a thrombocytopenia, especially if it was significantly below 100,000. Platelets transfusion may be necessary in the following. If signs of coagulations problem are evidenced clinically, if the platelets count is less than 20,000, or if a surgical procedure is planned. So these are the indications for platelet transfusions in women with preeclampsia. Coming to delivery, how to deliver the women. Severe preeclampsia is not a contraindication to vaginal delivery. Vaginal delivery, however, is not recommended in a pregnancy less than 30-week gestation with HELLP syndrome and Bishop score of less than 5. I mean, if the Bishop score is less than 5, go for cesarean section. But if it is favorable, still there is a place for vaginal delivery. How we induce it, we can use pitocin or prostaglandin, may be used to induce labor. Epidural anesthesia for labor is not again contraindicated unless we have severe thrombocytopenia. After delivery, the disease process usually begins to improve quickly, and within the first 48 hours, many laboratory values will have begun to return to normal, and urinary output should have increased dramatically, and the proteinuria usually will have diminished significantly. But we have to keep in mind always that in spite of this improvement, seizures can still occur up to 48 hours after delivery. What about timing of delivery according to the NICE guideline? Again, there is difference between NICE guidelines and American College guidelines. Timing of delivery, 37 weeks onward, initial birth should be within 24 up to 48 hours after stabilization of her general condition, so term. Record maternal and fetal threshold for planned delivery early birth before 37 weeks for the following indication. I mean, 37 is a cutoff point. If it is above, stabilizations and consider delivery. If below, the indication for delivery is or are inability to control maternal blood pressure despite using 3 or more classes of antihypertension in appropriate dose. So in spite of giving a maximum dose of 2 or 3, we have to consider delivery if it's still severe hypertension. If maternal pulse oximetry less than 90, I mean there is a risk of RDS. Progressive deterioration in liver function test, if we have elevations of liver enzymes more than twice, renal function tests, hemolysis, or low platelet counts. Ongoing neurological features such as severe intractable headache, repeated visual scotomata, or eclampsia. If we have placental abruption, definitely, and by Doppler we have reverse and diastolic flow in the umbilical artery Doppler velocimetry, and non-reassuring CTG or stillbirth, definitely. Before 34 weeks, if all of them not there, continue surveillance unless there are indication. Offer intravenous magnesium sulfate and a course of antenatal corticosteroid. فإذا معناتها أنا هخلي 34 weeks is a cutoff point. إذا less than it, we take all the measurements, and if stable, we continue. If not, we consider delivery according to the guidelines, we mentioned it previously. And we give magnesium sulfate as a prophylaxis, and definitely we will give steroids. From 34 till 36 weeks, continue surveillance unless there are indication, and consider a course of antenatal corticosteroid. So the Royal College guidelines go till 36 weeks of gestation. What about the timing of delivery according to the American College guideline? If the pregnancy is more than 34 weeks of gestation in a well-dated pregnancy, there is no benefit to delaying delivery once the mother condition is stabilized. فمعناتها two schools is there. Royal College 37 and above consider delivery. إذا below قسموها إلى less than 34 and from 34 إلى 36. بينما الامريكان college guidelines قالوا بأنه if the woman is 34 weeks and above, there is no place to delay delivery. Now, expected management has been advocated by some authors in those pregnancy with severe preeclampsia and less than 34, where the mother can be safely stabilized and there is no evidence of fetal compromise. The immediate goal of expected management is to delay delivery for only 24 to 48 hours. Why? In order to give antenatal steroids to improve fetal lung functions. 34 is a cutoff point. Longer delay may have other benefits to the fetus, especially in the cases of the extremely premature infant, as we know. Now, what about during labor guidelines? Blood pressure measurements. During labor, measure the blood pressures hourly if there is a mild, but if severe, every 15 to 30 minutes until blood pressure is less than 160 over 110 in a woman with severe hypertension. What about assisted vaginal delivery? Don't routinely limit the duration of the second stage of labor in women with controlled hypertension. Consider operative or assisted birth in the second stage of labor for women with severe hypertension whose hypertension has not responded to the initial treatment, so not routinely. After delivery, what are the important points that we should consider? Postnatal investigation, monitoring, and treatments including after discharge from the critical care. In women with preeclampsia who did not take antihypertensive treatment and have given birth, measure the blood pressure at least 4 times a day while the patient is inpatient, at least once between day 3 and day 5 after birth, on alternate day until normal if the blood pressure was abnormal on day 3 to day 5. Now, in women with preeclampsia who did not take antihypertensive treatment and have given birth, start antihypertensive treatment if the blood pressure is 150 over 100 millimeter mercury or higher. So I mean moderate form, we have to start giving antihypertensive drugs and consider measurement as a guidelines mentioned previously. In a woman with preeclampsia who took, previously the patient did not took. Now, in a woman with preeclampsia who took antihypertensive treatment and have given birth, measure the blood pressure at least 4 times a day while the woman is an inpatient, and every alternate day or daily for up to 2 weeks after transfer to the community care until the woman is off treatment and has no hypertension. For women with preeclampsia who had taken antihypertensive treatment and have given birth, continue antihypertensive treatments. Consider reducing it if their blood pressure falls below 140 over 90. And reduce antihypertensive treatment if their blood pressure falls below 130 over 80. If a woman has taken methyl dopa to treat preeclampsia, stop within 2 days after the birth and change to alternative treatment if necessary. Why? Because of the side effects of methyl dopa, and on the top of the list we have psychological upsets. What about blood tests? How frequent we should measure it? Hematological and biochemical monitoring. In a woman who have preeclampsia with mild or moderate hypertension or after step down from critical care, measure platelets counts, transaminase, and serum creatinine 48 to 72 hours after birth or step down. Don't repeat platelets count measurements if the results are normal at 48 to 72 hours after birth or step down. If biochemical and hematological indices are outside the reference range, repeat the platelets count, transaminase, and serum creatinine measurements as clinically indicated until the result return back to normal. In women with preeclampsia who have given birth, carry out a urinary reagent strip test 6 to 8 weeks after the birth. For women who had preeclampsia and still have proteinuria at 6 to 8 weeks, further review with GP or specialist at 3 months after the birth to assess the kidney function. Consider referring women with an abnormal kidney function assessment at 3 months for special kidney assessments. What about the role of antiplatelet agents? Advise pregnant women at high risk of preeclampsia to take 75 to 150 milligrams of aspirin daily from 12 weeks until the birth of the baby. Women at high risk are those with any of the following: hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as SLE and antiphospholipid syndrome, type 1 or type 2 diabetes, and chronic hypertension. Advise pregnant women with more than one moderate risk factor for preeclampsia to take 75 to 150 milligrams of aspirin daily from 12 weeks until the birth of the baby. Factors indicating moderate risk, and if we have 2 moderate risks, here first pregnancy, old age, a pregnancy interval of more than 10 years, body mass index of 35 kg per square meter and above, and family history of preeclampsia and multifetal pregnancy. Thank you so much.